Hello, everyone. Good evening. Today we are now closing our symposium. Actually, this is the last session, and we are together with three very quality doctors here. Dr. Baysan, Dr. Aylin Baysan is with us, Dr. Andrea Zandona, and Dr. Carlos Gonzalez. Let me introduce them briefly because I don't want to take your time a lot because we have small time I am sure they have many things to tell. So first of all, Dr. Andrea Ferreira Zandona. She's a professor and chair of Department of Comprehensive Care at Tufts University, School of Dental Medicine, US. Welcome, doctor. We are very honored here. We are very pleased to have you here. And Dr. Aylin Baysan, we all know her actually. She graduated from Hacettepe University, Turkey, School of Medicine and Dentistry. And she worked as an academic member of staff at Birmingham Dental School, King's College London, and recently, if I'm wrong, please tell me, at Queen Mary University, London, UK. Welcome again. We are very happy to see you here again. And Dr. Gonzalez Cabezas, he's a professor of oral and craniofacial global initiatives at the University of Michigan, School of Dentistry, US. He's a part of the Department of Cardiology, Respiratory Sciences and Endodontics, and the Associate Dean for Academic Affairs. Welcome, Doctor. We are very pleased to see you here. So let me introduce the panel. Our topic for today's session is the detection methods in clinics. So we'll listen our doctors about three main topics at this session. Let me introduce the first one, and we'll start with the discussion. The first one is the alternative methods to visual and radiographic examinations for approximal caries detection. I mean the developments about the diagnostic methods for early interproximal caries detection. We are listening to you, doctor. Welcome again.
Good evening. Thank you very much for having me. I appreciate being here and talking with my colleagues here and friends on this caries detection issue. So the first question on alternative methods to visual radiographic examination and developments about the diagnostic methods for early interproximal caries detection. So we have obviously, radiographics and bite-wing radiographs is the standard, but there has been a lot of development in this area. Interproximal caries remain a challenge for visual examination. There's some methods that are more promising. It's probably going to be based on transillumination. It's when you either use a device or even your mirror and light trying to go across and look in the interproximal space. So some of the methods that have been further developed and they're probably more promising for interproximal caries detections will be based on transillumination. Near-infrared light transillumination has been a promising for interproximal detection. We also have methods such as Diagnodent that is based on fluorescence that has an interproximal tip. And you have the photothermal radiometry and modulated luminescence that would be helpful for looking at in the interproximal space. Because the lesions are usually not, especially in the early detection, the early lesions, depending on the thickness of that enamel, what you're trying to look, it can be a challenge on looking at those lesions, and that's why radiographs has been very always reliable. Do you want to follow up on me? I think Dr. Gonzalez was following up. Oh, can't hear you.
Can't hear you yet.
So I think it's Dr. Baysan that's going to follow you.
Oh, I'm sorry.
No worries. Thank you. Yes, I agree with you, Dr. Zandona. Radiographs alone is not enough anymore, and if we all know that when the lesion is in the dentin, we can only see on the radiographs. So there are, I believe also in holistic approach. Yes, we have all these different methods of, diagnosis the dental caries. I also believe that when the patient comes, we need to think about the caries risk assessments. I think they need to be in future. We have all these research are disjointed from the diagnostic methods and caries risk detection methods as well. So we need to combine such as, methods like CAMBRA to understand the caries risk experiences, what is the patient's just the general health and oral health. And then in addition to this, we can look at the diagnostic methods, such as you mentioned, that nowadays the translumination is becoming very popular. And also clinically, some countries, these, selective separation methods as well work. At the same time, just opening up, like, when you are doing a orthodontic tooth movement and then opening up, and with the light body impression material, we can assess, but we can only see with these methods if it is there is a slight cavitation. So what we want is initially, isn't it, early detection is important for the minimally invasive approaches. For that purpose, I was going to discuss later on, but OCT methods, optical coherence tomography, is becoming very, I think, popular. And just recently, I just mentioned that as part of my MSc in MID program in the UK, minimally invasive dentistry program, I introduced MID webinars. And in our first webinar, speaker was Prof. Tagame from Japan. And he had a wonderful presentation on the OCT. And that OCT, still, like in the UK, the OCT system, optical coherence tomography system, is within the laboratory assessment, to be honest with you. However, in Japan, they already launched the system, and it's a wonderful approach. I think we can concentrate on that, because I have, to be honest, I have issues with Diagnodent type of laser fluorescence methods. I've been using Diagnodent, maybe you may notice, since like when I was doing my PhD, I was presenting the Diagnodent results when I assessed the different interventions for root caries, especially with the root caries. Diagnodent has different variables, and also even if you leave a little bit stain, so because it is relying on the fluorescence effect of the microorganisms, this is the the company or the developer, they claim it is very variable. The results are not really reliable. Therefore, I think we need to look for different methods. Again, it's all about either the sound tooth tissue optical sort of reflection properties or translumination properties, or microorganisms fluorescence effect as well. So we are really relying on the local factors. But what I am trying to say, I will finish now just because of the time, I am looking for more holistic approach, general and then local factors. I think we need to look for, even for diagnosis as well. Thank you. I think Dr. Gonzalez.
Well, I agree with with both of you have said. So, but let me mention my angle a little bit. The first thing is being a little bit disappointed with the progress of radiology. I don't think that we're better diagnosing. I mean, the technology that we have in radiographs, it is no better than it was 20 years ago. And this is really very disappointing. Maybe we have reduced the exposure to patients. That is true now with digital radiographies, but but really the quality of diagnosis is no better. Even subtraction, that seemed to be a promising method that we used honestly in the 90s. It was a long time ago. It still is no better today. Okay, so this is very disappointing because I do believe there is a lot of room for improvement there. And maybe Convene CT will be the future in which you scan three-dimensionally and you start to get data there. But right now we don't have anything available that we say that is better than that. The second thing I wanted to mention is activity. This is a tricky one because usually in interproximal detection, we're looking just for damage of the enamel or the enamel in the dentin, right? And the reality is that many of those lesions that we detect radiographically, especially those ones that they are still in enamel radiographically, they are arrested. They develop when the patient was a teenager, and if sometimes they are detected when they are young adults or even older adults, and they are restored at that time, which is very disappointing. So if I can give one recommendation to the audience is to really look at all the radiographs and make sure that you find some evidence that the lesion is advancing, because very frequently many of those lesions are arrested. So this is, I think, that's a very important point there. Now the last thing is, one important determining factors in detection of proximal lesions is the detection of the cavitation of the surface. I think that is a very pivotal finding because changes automatically the treatment plan. Yeah. So, and sometimes, unfortunately, it's difficult to determine that. And even when you look at the literature to try to correlate how advanced the lesion is with probability of cavitation on the surface, the literature is very inconsistent. So you're gonna hear people speaking, including myself, mentioning this is the probability if it's the DJ, if it's in the outer third of dentin, of it's so on. But it's really based on very small studies. I mean, sample size and not consistent. When you see data from Germany, from the UK, from the Scandinavian countries, the differences in percentages are very big. So it's very difficult to be consistent in our message to say, a lesion that radiographically is reaching the DJ, you will have, let's say, 50 to 7% chance of cavitation. And I'm making up these numbers, okay? But if you go the next study, it's gonna be maybe only 10%. And then you go the next study, it might be 40%. So it's very difficult for the clinician to use that data. Now, separation, as Dr. Baysan was mentioning, is an interesting alternative. Traditionally, we use that with ligatures, with orthodontic, rubber bands. And the disadvantage there is that you need 2 appointments. You put it there, your patient has to come back in a different appointment. A few weeks ago, there was a publication that came out from, I think it was Sweden. There was one of the Scandinavian countries. I apologize, I don't remember where it came from, in which they were using a device to do the separation at the same time. There was basically a little thing that you put there, you was kind of torquing and separating this, and they were measuring actually the pain in the patient as well, which the patient could feel it, but the argument that it was tolerable. Okay, but they were able to make the clinical detection of the surface at the same appointment, which is a big thing. It's a big difference for that technique. So I think that's something that we will be looking in the future to see that become more standard of care. When you detect a lesion probably radiographically or using transillumination or other method, and you really want to determine if the surface is intact or not, and then you use one of these methods for separation and be able to see the surface directly. In this case, this paper that I'm talking about, the study, they were placing sealants in those surfaces. So whether they were microcavitated or non-cavitated at all, they were placing sealants, and to get access to that, they were doing this separation in one appointment.
Oh, I think you bring up a great point, both of you, Dr. Baysan and Gonzalez. It's the separation and both starting addressing and assessing if it is cavitated, because that is a major intervention point, because a cavitated lesion in the interproximal surface is more difficult to arrest because of access. And the separation, so that you can actually determine that, because you can't really identify that by other means. This what you're talking about, you probably remember there's maybe some form of gold foil way back in Indiana. When we looked at that, it looks like a medieval torture device that separates the tooth, but it's it's tolerable, and patients may be very willing to do it. And you can do the separation also in office. Sometimes it's not as convenient, but if you place the separator when your patient comes in for the appointment, for the screening appointment, and ask them to come in schedule them 1 or 2 days later for the restorative appointment or your first appointment, and then you can include that in your practice. But those are major things. There are other methods, and you said that there's very little that has been going on, and it's true. Progression has been very slow. There is something that is coming out of, it's called stationary intraoral tomography, tomosynthesis, that have been looking at, but it hasn't been shown to be better than radiography. So it's, people keep looking at it and looking at AI to determine if we are better at detecting the lesions. Maybe if our eyes can't do it, the computers can do it. But so far, we haven't had a very progress that is significant.
I think this point of AI is very important. I think maybe 10 years down the road, so there will be the computer, probably AI, artificial intelligence, that the computer can analyze a set of radiographs historically, probably, and can probably predict much better than we can if the lesion is active, in taking consideration different angulations, different quality, and all those things. Right now we have limitations to interpret. So,
I will just add one more point, if I may. At this stage, we are aware that CBCT is not being used for dental caries, but I think that if you remember, when CBCT first introduced, we wouldn't even think of limited sort of for CBCT for endodontic purposes. So in future, maybe, it's just my sort of thought process, I'm thinking loud, maybe artificial intelligence plus CBCT, very limited areas that, especially with the interproximal dental caries, can be an option as well. But I wouldn't recommend, whoever, if they are watching, it's not a CBCT at that stage, it's not a regular method for detection of especially interproximal caries.
Mm-hmm.
But in future,
it's possible, but it's not there yet. Yes,
not there yet. Yeah.
But I agree for both of you.
Doctors, there are some questions. Oh, sorry, Dr. Zandona, please.
No, I was just going to say that it's
there are some questions.
Will be helpful because some of those imagings is just very hard to interpret. If you look at the OCT images. I see the questions, if dental floss alone is enough for clinical detection of proximal lesions. So that has been something that, as clinicians, as when you're in dental school, that's how you learn. And if the floss breaks, then there may be a lesion there. And it can be helpful, but I don't think it's enough, especially for some of the initial lesions. I personally rely a lot on tooth separation if I wanted to determine if that surface is cavitated or not, because I think it's nothing like looking at that surface and have a clear visual of that surface.
And another one, as you are the caries masters, what do you think about the fluorescence and ultrasound? As I use both of them, the fluorochem and ultrasound, in my doctorate thesis actually. I was wondering that what are your opinions about those two methods for the diagnosis? Dr. Gonzalez?
Could you please repeat these two methods again?
What do you think about the fluorochem? I mean, the autofluorescence based devices like QLF or fluorochem, and the ultrasonic system for the caries detection, or even the detection of the demineralizations, actually.
but we're still talking about proximal lesions, right?
Yes, yeah, right.
Okay. So for the visual methods, whether it's clinically or using fluorescent labeling and looking at this, still you have to have access to the area to be able to see it. So even if you're able to label that and see the fluorescence theoretically, let's say with QLF or so on, but if you cannot see the area directly, you cannot capture the signal. So that is I don't see how you can improve that by using QLFD detection in that area there. A potential use in the future is using small cameras like the endoscope that is used of the periscope that are used for endodontics and periodontics, that you just very small cameras that you could place there, and perhaps you could see the fluorescence if it's designed that way. As far as I know, nobody has developed that yet. But anything that requires a visual observation there, you need to create separation or create something small enough that can reach that area. So for the ultrasound, I did a study many centuries ago. See, it feels like, but that was with the smooth surfaces, for ultrasound, and it shows some potential and so on. But at that time, the limitations were too big. It was not practical. And I honestly haven't worked anymore in that area, so I cannot tell you if maybe the technology has improved and it's been more amenable for dentistry. For proximal issues, maybe Dr. Zandona, Dr. Baysan, they are more familiar with that. Right now, I don't have any information to share with that.
Okay, thank you. Dr. Baysan, Dr. Zandona, do we have any opinions or something to add?
Yes. So I don't know if you know SopraLife is a laser fluorescent camera.
Mm-hmm.
Have you heard? So this is it's a developed system in France, and we just did one lab-based study, and I am hoping to use the SopraLife camera. What Dr. Gonzalez is not like a mini. I would have the prop is I would have had it sort of smaller in size sense. It's like a diagonodent probe, so maybe you will, camera wise. But what we found is we were looking for the early enamel caries, and we used we are going to talk later on ICDS, and we looked at the correlation between the ICDS results and ICMMS and also SopraLife. And that kind of system has a promising future, because what we found is with the ICDS methods, unfortunately, we are going to talk about some of the very early, like even interproximal lesions can be, you cannot access anyway, so you are not going to really detect them. With SopraLife, there is a potential that we can detect the interproximal non-cavitated early lesions. But this is a lab-based study. There are some studies, the clinical studies are the issue with the clinical studies, as Dr. Gonzalez mentioned, the variables are always different, the population different, sample size is different, so we cannot compare. But currently in the literature, there are some studies from the France, and please have a look. I am happy to put it on the chat box if you're interested. But SopraLife camera has some promising future in relation to, I think, of course, the radiographs and for me, again, I keep saying the assessment of the patient themselves.
Yeah. So based actually the ultrasound, right now there's not enough data to say too much about the occlusal and proximal surfaces. We do know that it can work on smooth and root surfaces, but not enough data to tell us about proximal surfaces.
Okay, thank you. Let me introduce you. Let me go with the other subtitle maybe, because we are running out of time. Mm-hmm. So The second subtitle is the population-based methods for caries detection. How would you start, Dr. Baysan?
Yeah, I think it was with me. Thank you very much. Really good questions. So around 1980s, isn't it? There was a consensus that it would be good to have a population-based approach. And initially, DMFT index was introduced. I have issues with DMFT, and I am happy, to discuss if you wish. But nowadays, I don't think so. We should be using that index, decayed, missing, and filled index. This doesn't really give us such as missing teeth. Are they from the, related to periodontal disease or dental disease? We don't have any sort of specific knowledge. How about ICDS? And I'm sure Dr. Zandona and Dr. Gonzalez, you worked with ICDS group, I believe. So this is a good move. It helps us, ICDS, International Caries Detection Assessment System. It helps us with the clinical. We rely on the clinical picture. Of course, clinical finding. Of course, this ICDS, when it has been assessed, they are validated to the histological appearance of the lesions. And at that stage, I think this is the most reliable system that in the world, and mostly validated system we can use. But still, I have issues with the ICDS from the root caries perspective. And when I spoke to one of the researchers in ICDS, and they acknowledged as well, because if you have a look at the ICDS, it's only for coronal caries lesions. When we look at the root caries lesions, it's very broad. Their scoring system is very broad, so it doesn't really eliminate the early root caries lesions, and in an active stage, or again, early caries lesions is going to the cavitated stage. You may say that clinically, is it really relevant for us, for clinicians? Yes, this is another question as well. However, out there, dental practitioners, they need to have some sort of understanding on which lesion they can prevent, or they can manage with the antimicrobial agents or chemotherapeutic agents, or which lesions they can do for the restorative treatment. So I see this is a good starting point, but I have still issues with that system as well. I mean, so far, I think these are the main, mostly validated population-based systems that, for detection of dental caries.
Thank you, Doctor. And Dr. Zandona, do you have something to add, or Dr. Gonzalez?
Yes. So the population-based method for caries, I have worked with ICDS for many years. I'm actually right now today in doing a calibration. So I have outside here 5 examiners who are looking at patients for completing a calibration on ICDS for a clinical study that will start. And I agree, ICDS for root caries has not been as developed as it has been for coronal caries. And it basically just breaks down the surface for initial and then cavitated. There is no in between, and it is a wide range there between what you do. But I think I'm going to go back to something that we started talking about, and Dr. Gonzalez was talking. It doesn't really matter. All the severity is important in terms of management, but more important than that is of course determining if this is cavitated. As we were screening subjects for this study that we are doing right now, we are also assessing activity, and activity is extremely difficult to assess, especially visually. And as I'm, looking at the data from these examiners, I'm seeing, the wide range, and things that I clearly think it's active, somebody else will clearly think that it's inactive, because we have very little based on just the clinical presentation of the disease. We need to have, more information. And when we go for population-based, that we are just looking at the data for an overall, the community, clearly, especially if you're looking at adults, we're going to have a lot of lesions that are arrested and has no impact on, on progression. And that should have a significant impact on how and what type of treatment you need to give to this population.
Thank you, Dr. Gonzalez.
Yeah, and let me. I'm gonna take a little bit, maybe a tiny bit controversial position regarding the MFT, and I'm gonna defend the MFT a little bit. Okay, it has been historical. That's the data that we have historical, and it was designed in a time where caries prevalence was much higher. So focusing on non-cavitated lesions didn't make a lot of sense at that time when there were so many people with so many cavities and so many teeth, right? So, and also from the perspective of activity and predicting what could happen to that tooth and to that individual, cavitated lesions are much more predictable. That if you do nothing, the consequences are probably in most cases detrimental for the tooth and the individual, right? Non-cavitated lesions are still, regardless what the papers say, many papers, it is a very experimental area, trying to figure out what lesion that will progress and which one will not. There are a few indices out there to try to guide the clinician on how to determine that. But when you look at the validation of those indices, they're not very strong. I mean, because it is difficult. And Dr. Zandona did a pivotal study in Puerto Rico in children and young adolescents. And in paper, because I reviewed the proposal, everything looked perfect, straightforward, and these were high-risk population. We're not talking about the average population, high-risk population. They were young. So those lesions that appear to be active in this population, we thought, or she thought, that were very likely to be active and continue. What she found out that many of them, they don't, even though they were all the hallmarks that you would expect for that. So makes you pause about this diagnosing part. So I just to wind this up, so that I'm just trying to defend a little bit the MFT in the sense that when you really detect a cavitation, you really have a problem. And the population-based perspective, it should be an indicator that for public health programs, there should be an indicator for many other things. And non-cavitated lesions too, but I think we need to see it from a different angle, because they will be affected by many other factors. For example, the exposure of fluoride of the population, how frequently people brush with the fluoride toothpaste or not. So it could be very different from population to population. I wanted to mention also one more thing about root caries, because that is also a very tricky one in which we measure root caries activity based on hardness. Denting in general, we measure activity based if it's soft or not. And now that I have been doing a clinical trial for 2 years in very young children with cavitated lesions that we're treating with silver diamine fluoride, and we're measuring hardness as an indicator, I can tell you how complicated it is, okay? And to begin with, most lesions have different areas with different hardness level. So you might be in one side that is relatively soft, another side that is relatively leathery, another side is maybe dry leathery, and the other one that is hard. So the question is, is the lesion soft, leathery, or hard when you have all three portions in the same lesion? And that is very, very common, okay? I'm not talking about exceptions to that. And then the ones that are very soft and the ones that are very hard, they're relatively simple. The problem is that most of them fall in the middle. So, and how soft do they need to be, or how leathery they need to be? And really, we don't have a lot of data. I mean, we base this in a few studies done in the 80s about sample collection from some dentists that were done, not all of them, but many of them using cavity preparations, and then they were measuring how infected the dentin was, right? And so there is a lot of room for research in this area, in my opinion, for us to try to determine activity and how that correlate with progression of those lesions, because many of those root caries lesions, they arrest by themselves as well, as I was saying before with proximal. And it's not that clear why. I mean, sometimes you can correlate very well with brushing and use of fluorides and stuff like that. Sometimes, honestly, with some of my patients, I'm not sure. but some of the lesions, at the same time, sometimes I don't know why some of the lesions progress. You know, it's a very difficult area to be precise with diagnosis and to manage. Because I do think there is an association with salivary conditions,
yeah.
And those might be not very consistent as well. The patients might go through different periods in which they have better salivary flow than other periods, maybe associated with drugs, maybe associated with other factors that make very difficult the determination of activity. Dr. Baysan, I think you wanted to say something.
Yes. Can I?
Thank you for your very knowledge.
Yeah,
Please,
yes,
Dr. Baysan.
This is very close to my heart, because last 20 years I've been working on root caries, and still, you know, the research, if you notice in the literature, it is very limited. And you are right, because the more I see since like from 1996, we haven't moved, isn't it, a little bit, even 1 mile or anything. And this is the complexity because of the organic part of the dentin. This is our issue. This is why, you know, we don't see that sort of, if it is heart everywhere on the lesion, of it is some part is leathery close to the heart. This is what I meant with the, you know, we need to have a little bit more detailed classification, like we are using severity index for root caries, and we quantified this, like we categorized, if 0 is hard, 1 is leathery type but approaching to hard. We need something like a system, and it needs to be widely validated, because this severity index used by main, I think, UK based, and by myself and by my supervisors, PhD supervisors, etc. It's not widely used. And also, yes, I agree with you that, you know, these root caries lesions, definitely there is a relationship with the saliva, the quality of saliva as well. I see this with my own patients, with our clinical studies, with my PhD students studies as well. This is why, in what you know, as you say, from at the beginning of the study, the saliva sort of different. You know, with one of my PhD students study, we used dental varnish recently, and hopefully, you know, we submitted for publication. We used dental varnish with fluoride, and then dental varnish, fluoride and calcium and phosphate in a dry mouth patients. And when we looked at after 3 months, there was a difference between these two varnishes. But after 6 months, and of course after 3 months, the dental varnish fluoride with calcium and phosphate performed better. And you would expect this because it's a dry mouth, so additional calcium and phosphate will help. And then after 6 months, there was no difference. And when we look at the salivary quality, we looked at different ions as well in this in that saliva, and the quantity is changed. So I mean, the dental varnish is not going to change isn't it, the saliva quantity after 6 months. So you are right, it's like a periodical general health is affecting these patients' local, you know, local factors. So I don't know. It's like, I feel like it is like a vicious cycle. The only one point that I know last 20 years that I am working on the root caries, non-cavitated lesions. When there is a cavitation, there is no way that we can have any without restorative treatment. There is no way that we can use any chemotherapeutic approaches. This is what I know. So this means that, again, coming to the detection, I don't want to divert our topic. Early detection is important. Yeah.
Thank you. Dr. Zandona?
Yeah, I'm going to go back to a little bit with what Carlos said, because in terms of, yes, if we have cavitations, it's important. But if we are trying to look, depending on the population that you have, the DMFT may not be as helpful, because you may have a very bias towards, just that small population that are having those cavities, and you're missing those initial lesions. And if those initial lesions are active, then you are missing really the prevalence of the disease. So I disagree a little bit. Of course, in your patients in the chair, it's very important. But I do think that it's even at population level, depending on where you are working with, and if you're really focusing on prevention, if you're missing the initial lesions that are active, and again, you mentioned we have done studies. There are very few that are really going to progress, and it's very hard to determine which ones are those. That study that Carlos mentioned, I think we at the end it was like 10% of those lesions actually progressed to cavitation in a very high risk population. So the goal is to identify those very few for whom that is a problem, and focus prevention on those very few. And it's still a challenge.
Actually, at that point, there is a question about that. You talked about the active lesions. What about the arrested lesions? The detection of arrested lesions by an instrument, I mean, by visual inspection or with a periodontal probe, is it enough? Or do we need to use another technique with these? Because mainly in the clinics, people do that with visual inspection and with probes. So what do you think about that?
I can take that if you guys want me to start with. I believe that what the person is asking, if using an instrument to determine the roughness of the surface can predict activity, because that has been published before, and it makes sense. It makes sense from the understanding of how caries lesions develop. And in practice, it might not be as simple as that, because that is maybe more practical for smooth surfaces. But most lesions develop in pit and fissures, and second in proximal surfaces. And for those areas, measuring roughness of the surface is not as easy, especially we're talking about early lesions. If they're more advanced, for example, pit and fissures that go outside the fissure, and maybe you can do it there, but those lesions are more advanced. What we call in ICDAS will be a 2 at least. So I don't know. And then for smooth surfaces, and we, in this case, we're talking mostly cervical lesions in most situations. And I think they can be helpful as part of the assessment, of the appearance and the roughness, and also the association with plaque. I think that's very important. If the patient, especially after brushing, you find that there is a stationary plaque, a stagnant plaque that hasn't been removed, and then after you remove it, you find a non-cavitated lesion that has an appearance that is opaque, like we call chalky over here. In addition to that, you go with an instrument, you find that it's rough. All those things combined I think, increases the probability that that lesion is active. But again, this is a subset of the lesions that rather small.
Yeah. And that are less likely to progress anyway.
Correct. Because they have better access to
fluoride and
for fluoride and cleaning, whether with a brush or just self-cleaning with the cheeks and other typical mechanical forces that they are exposed to in the mouth.
Just I have one point it's like a comment or maybe question. These arrested lesions, I have some concerns about them as well. As we know, arrested lesions are sort of more, they are very resistant to the dental caries compared to even the sound enamel. It's fine. How about the subsurface, like an eggshell effect? Outside, we know it is arrested, but subsurface, maybe there is still some activity going on. How we are going to, at the clinical level, how we are going to detect this? At that point, I think OCT, optical coherence tomography, is going to be promising. Just one comment.
Actually, you mentioned it 2 years ago. I was with Dr. Yunya Tagami, Professor Tagami.
Yes.
I had the chance to take 4 days of education about optical coherence tomography there. They were these days they were using it in laboratory, but he showed me about they are doing some research about the bulk fill materials, and he showed me with just the light the gap formations in the cavities after the restoration. So I want to ask you that is it now available for the clinics or not?
Yes, they just launched the company, a commercial company launched their system. This is Prof. Tagami introduced us, and it's only available in Japan now. And so they have OCT has the ability now to detect the subsurface lesion, and also I think we will discuss this in a minute, secondary caries lesions as well.
Yeah, okay, yeah, for sure.
Of course, it's only, we are relying only on their data. It's again small studies and lab-based studies. They have very small clinical study, but I think the future is going there. This worries me that we are using all this in the UK. I'm sure in the US as well we have this. Part of my PhD was about this 5,000 ppm fluoride, high fluoride for high risk patients. But I have concerns about this toothpaste because we don't know it has an eggshell effect in all these lesions. It's not that straightforward for us if outside the surface is arrested.
So let me make a comment about that, because I think it is important. And like many of those things, there are many nuances depending on which specific detail we discuss. But I want to bring back to the attention of our change in our understanding of the dental caries process, because I think all of us here probably were trained under very classic paradigm in which caries was seen as a gangrene. That's what comes from the black time, and then the techniques were very aggressive. You find any sign of the disease, you remove it, you make sure you get to sound, enamel, and denting, because it's like cancer. If you leave a few cells there, it's going to grow back again and it's going to kill the patient, right? And caries have been seen that way, and I was trained that way. You have to be, this is very important. And it's still in the US, most dental schools, a lot of the cavity preparation for restorative is seen that way. Maybe not as aggressive as it used to be. Now we leave sclerotic denting, where sometimes we leave even caries tissue if it's close to the pulp. But I'm sure it's not in every school. It might be in the more research-oriented, like my school and the school of Dr. Zandona and Dr. Baysan. But still, we have this background, in which affects a lot of the mentality about this. And I do think that this idea of this concern of the subsurface lesion to continue, which is a very common concern. This is not unique. So it's quite common, comes a little bit from that background, in which we feel very uncomfortable to leave carious tissue underneath, because we think that might progress again, right? And now, but let me divide this between lesions that are limited to enamel to lesions to dentin, because I think this is important. Lesions limited to enamel, honestly, I have a hard time to figure out a way to explain why you will be concerned, because it's just basically mineral loss with some acquisition of organic matter from the environment, from saliva and the pellicle and the biofilm. Other than that, this is what it is. It's just a very inert tissue with less mineral. So from that perspective, I'm not very concerned at all for the enamel lesions as long as you control the surface. Now, dentinal lesions is a little bit more of an unknown. There have been several studies in which they have sealed carious tissue intentionally. There was a very famous study done in Michigan a long time ago in the 80s that everybody reports. And there have been a few studies done, especially in Brazil and South Brazil and Porto Alegre in the last 5 years or so, that show that for the most part, if you seal the lesions and dentin, those carious lesions, they will arrest. Maybe not all of them, but most of them will arrest. And then when you balance that with prevention of root caries, root canal treatments, and so on, this seems to be a positive. Now, I understand that. I personally, maybe I'm Dr. Baysan's side here, I'm a little bit concerned with that we are preaching around that it's okay to do that with perhaps insufficient data. I don't know if we have enough data to say that we can leave carious denting everywhere, it will be fine. And there are some indications that we can control certainly the biofilm by sealing the lesion. We can certainly, there is enough data that suggests that most of the bacteria will die or will become very inactive or will survive by expressing different genes that will prevent them from making acid. So I'm not that concerned from the carious process from that perspective. I'm more concerned with the host enzymes that get released during the process. And when I talk about matrix metalloproteinases and DNases that get released from the dentin during the process and get activated, and they can have still significant damage to the organic matter. That portion of the lesion process, I don't think we understand it well enough. We're still discovering that. And I don't know what that means. It could be that in the future we place actually some enzyme inactivators in our management of the lesions that will control that, and then we can maybe leave the lesion there, and that would be fine. This is my personal view, okay? I'm just talking personally. I think we need to be a little bit cautious how we make recommendations about this carious dentin, because in my opinion, still there is a lot to discover there.
Okay, thank you, Doctor. Okay, thank you for your valuable information. So let us, we are out of time, so let us go through our third and very last subtitle, actually. We just started, we have started about talking about that too, actually, but detecting secondary carious lesions.
I think that's me first. So this is an interesting area because a lot of the data that we have from the studies came from lesions around amalgam restorations. And nowadays, and I don't think that's an issue because most places amalgam restorations is a very small percentage of the restorations. So we're talking about really mostly resin composite, right? Restorations. And one thing that it is important to me that has changed a lot, it is our understanding of secondary caries in the last 20 years or so. And in the 80s or maybe even 90s, there was a very strong belief that micro leakage was associated directly with secondary caries, with caries developing there. I think there was enough evidence, enough data showing that a small leakage has very little relationship with caries developing in the interface there. So it needs to be a gap size with enough size to allow the exchange of fluids between that gap in the environment. And it is not clear what is the right size is, but some people have proposed 200 microns. Some people have proposed 100 microns. Some people 50 microns. It's not very clear. But there certainly is no micro leakage. It's not a few microns. For example, a break of bonding alone might not be enough to develop secondary caries in that area. Now, there are a few factors that might be important, though. It is, for example, if the bond breaks and the restoration moves, that is a significant accelerator of lesion formation in the interface. And that is something that some people propose to put retention for composites, for example, and that is potentially a big problem because you will have the if the bond fails and you have the restoration lock into mechanically into the cavity preparation, and then caries development is very likely to happen and very fast. This pumping action that there will be demineralization, and every time the patient chews, pushes out all the minerals that have been demineralized, lowering the saturation of that space, that will accelerate the process very much. Now, from the detection side, honestly, we don't have much more than what we have talked before. We're still using very similar methods. It's still very rudimentary, if you want to call it. One thing that has changed, though, again, is the interpretation of radiographs, for example, and also the interpretation of the margins. And staining, for example, in the past, staining was always quickly associated with decay. Now it's not. If you do that it shouldn't be, the staining of the margin of the restoration. Radiographically, we need to be very careful because many bonding agents, they're radiolucent and show a space between the resin composite and the cavity preparation, and it's not necessarily an indication of dental caries. It's just an indication of pooling of the bonding agent. Another big challenge is, going back to what I was saying in the previous point, is the aggressivity of removing caries. Now, many dentists, especially cariologists, were much less aggressive than before. So we leave intentionally denting that can be radiographically seen as decay, and it doesn't mean that we have a secondary caries. And what I mean with secondary caries is new caries developing along the restoration, not the residual caries. So interpretation of all this information is super critical. So I do strongly suggest for people that use radiographs as a determining factor for removing a restoration, that wait until you see change from one radiograph to the next, because there are many reasons for having a false positive of secondary caries in these cases. But I would like to hear what everybody else have to say.
Yes, so thank you, Carlos. I miss working with you on secondary caries way back. Lots of studies and looking at teeth and trying to actually find secondary caries on teeth.
Yeah.
You remember that one study, because it's not, it is the reason why most dentists remove restorations, but it's not likely that there was a lot of secondary or new caries around those restorations. And that's an issue. I agree that our diagnostic or detection methods are really very poor. And we still struggle with that decision. Is there a lesion there or there is no lesion, especially, should we remove that restoration? Keeping in mind that, even the best of dentists is always going to remove a little bit more tooth structure. And, thinking of preserving tooth structure, that's not the best. And I think what you said, let's see a change in the radiographs if that's your criteria. And, keeping in mind that it takes a long time and we are always so worried about what's going to happen next. I think dentists are always like, but what if I don't do it? And the next time I see the patient is going to need a root canal. And I think that's the most common reasoning I hear from practicing dentists in terms of aggressive treating, both for primary and for secondary caries, is if I don't treat it now, next time I see this patient, they're going to need a root canal. And I think that goes, beyond what we are talking in terms of knowing your population and knowing, your patient and understanding the disease progress for that patient and for the population that you are in. Dr. Baysan, do you?
Thank you. To be honest, Dr. Gonzalez and Dr. Zandona explained really nicely. This is what I was, thinking of my head, and the way you structured it was so nice. And maybe I should say something for the sake of, but you exactly what I believe genuinely. You are right, Dr. Zandona. Population, we need to look at the population. And yes, we see this as well. They say, oh, if I leave this caries lesion, is it going to progress? And I genuinely believe in Dr. Gonzalez about the limitations, still lots of limitations in the detection. And I think also the bonding agents, I genuinely like our students. I'm sure your students, as with the digital radiography, especially, they call me, they say, "Oh, Dr. Baysan, this is all carious lesion." I said, "Look, calm down." And then suddenly, when Dr. Gonzalez, when you mentioned this, I said, "Yes, I know." And yeah, I think, as I mentioned, this is what I was going to say, the combination, and you did really a very good job. Thank you so much. For me, again, the holistic approach of the patient will help us. And also, we need to think about our aim. If we, our aim is to detect this secondary caries, and then what do we want to do? This is important as well. Are we going to repair or replace? Maybe, yeah, isn't it? So always, the end product, once we detect, okay, what are we going to do?
Let me make a comment about that, because I think that's very, very important. One of the big advantages of composites is that ability to repair that. So if you have a margin that has a gap where the explorer can get in, there is not really a good excuse not to repair that, and then you can be minimally invasive, just go there, remove a little bit of the composite, try to minimize the damage of the tooth structure, and just repair that. It's very simple, straightforward, and very effective.
Mm-hmm.
And doctors, may I ask you a question actually, that I was wondering. Nowadays in Turkey, some dentists is going up and up, and some dentists are removing the hard tissues of dental hard tissues just because of they examine some kind of enamel cracks on the occlusal parts just because of bruxism or occlusal trauma. Is it correct, or should we need to just see them in the long term? What happens next? Because they are worrying about getting them demineralized. So they want to remove it and doing the composite fillings, but in my opinion, it's not a better thing to do that. So what's your opinion? Thank you.
Well, I can start with this because I have, I guess, a strong position, and I don't know, Dr. Zandona, Dr. Baysan. There is a lot of overtreatment associated with cracks, okay? If your population, it depends what is your patient population. My patient population, my personal patients are on the older side, and I can tell you, those teeth that are not crowned, they have cracks, but almost all of them, posterior teeth. So if I have to use cracks as an excuse to place crowns, they all will have, every tooth will have a crown. So some of those cracks, though, will progress and might cause a fracture or might cause, cracked tooth syndrome and so on, but those are a minority. Okay, those are a minority of those. And as far as I know, we don't have a good way to predict which ones will progress that way or not. In my personal experience, which is not that big because I don't see patients every day compared to people that work full-time, I think I have only one patient in which the tooth crack and went all the way to the pulpal floor, and we have to extract the tooth and place an implant. And all the other ones that we've been able to manage in different, in other ways, and those are the very small minority of that. Now, going back to caries, which is our discussion, no association with caries that I know of. Usually the issue with cracks is pain or physical, that you lose a portion of the tooth, which cracks are common, and it's going to happen more and more because our patient population is getting healthier, so more people are retaining their teeth without crowns and for a longer time. So this teeth mechanically is being exposed to these stresses for longer time. So crack propagation is going to happen. Small cracks that extend over time until they break. And the same reason that we have this, you're going to see this change because people are getting healthier. It's also maybe putting pressure on dentists that they actually don't have as much work to do related to caries and other things. So if there are, especially in countries where there are too many dentists, that is an issue. Financially, it is a problem that people don't have enough treatments to survive or to sustain their thing. It's a tricky thing. That's an ethical thing. So, but I would like to hear what Andrea and Aylin have to say.
Thank you. So, Dr. Baysan and Dr. Zandona.
Okay, thank you. So I totally agree again to Dr. Gonzalez, and we need to look into firstly general factors. Again, holistic approach, general factors, local factors. What is the patient's occlusion is quite important to understand, and then parafunctional habits like grinding, clenching, and then also the local factors, the tooth itself. What is it? Is it root canal treated? It's a different process, isn't it? We need to have a very structured approach. I know sometimes it's not that easy in a practice environment when you see, but if we can sort of think about all these factors, it will help us to determine what we can do on this tooth. We cannot, for me as well, Dr. Gonzalez is right. For me, it's not really ethical to have all the cracks and then, even there is a little bit dental caries removed and include the composite resin. It doesn't really make sense to me. And from my experiences over the years, we all, isn't it, we are in academia. And also I work in practice. I see patients in the hospital. I rarely see suddenly, lots of cracks and then developing a cracked tooth syndrome, unless the patient has some sort of parafunctional habits. Usually, we have patients is unless the root canal treatment done and one marginal ridge is missing, etc. So we need to look at the factors, and I think it's a very good question. I worry about all these different interventions in different countries. So I hope it will be helpful for the audience. Yes, thank you.
I'm not sure I have much to add besides saying that you can't really just look at one thing. When you're treating a patient is different than what I'm doing right now, which is calibrating people to look for caries. When you're treating a patient in the chair, you have to look at everything else that's affecting that patient and make a decision based on that patient that is sitting in the chair at that time. So it's a little different, yes.
Can I make a quick comment that was reminded to me, and I don't know if you guys have noticed this. In my patient pool, I see more fractures and failures right now, and which I think is related to the pandemic and people doing more parafunctional activity. Yeah. I think it's very, very fascinating. I have in the last 3 months, 2 crowns implant crowns that broken the screws, which is quite uncommon. I think I have one before ever. And it's associated people being stressed out and their lives being upside down. So
a lot of grinding going on.
But here with the economic upside down, our situation is more adverse, actually. I can say that, because people clenching their teeth more and more every day.
Yeah.
So I'm very happy to hear those from 3 masters of you. So thank you for that. Thank you for your valuable time. It's been more than 1 hour, and thank you for your patience. Because when I see those 3 masters together with you here, it's incredible. So everybody just wanted to hear more and more from you as much as we can. So again, thank you for your valuable contributions and informations and valuable time. Thank you very much.
Thank you. Thank you for the invitation.
Thank you.
Thank you for the invitation. And thank you for my co-panelists. It was wonderful because this was our first, isn't it, panel?
Yeah.
And really enjoyed. Thank you so much.
Yeah, me too. Thank you. And just 1 second, I think Dr. Funda would like to talk to us at the end, just to let you guys don't leave. I think that's...
Thank you.
Thank you very much.
Thank you, Dr. Corkut.
Thank you.
It's so good. Yes.
Thank you very much.